Good morning, everyone. My name is Sylvia Soltis, and I'm the Pro Bono Director at Legal Aid. Thank you for joining us for today's Medicare Part D training. I'm joined today by my colleagues, Andrew Patterson, a senior staff attorney in Legal Aid's Public Benefits Unit, Jess Davis Ricci, a staff attorney in Whitman Walker's Legal Services Department. It's hard to believe, but this is our 17th year doing this Medicare Part D project. Whether you have been with us since the very beginning or this is your very first Medicare Part D season, we're grateful to have you with us and sharing your time. Simply put, our organizations could not do this work without your help. So thank you for making time to make sure our clients are in the best plans for the coming year. A few quick housekeeping items. We are recording this training and we'll share the recording before the end of the week. If you have questions throughout the training, you are more than welcome to type them into the chat or the Q&A box. We'll answer all the questions at the end of the training. So we thank you for your patience. I'm also going to pop back on at the very end to discuss next steps for both of our organizations. We have different processes, and it's helpful to understand how things will move forward after the training and in regards to your client assignments. We have a lot to cover today. So all that said, I'm going to now turn it over to Andrew Patterson, who will help us dive right in. Thanks, Andrew.
Thank you, Sylvia, and thank you, Jess, for joining. And thank you, everyone who is participating in the training. I'm just going to go ahead and get started because, as Sylvia said, we do have quite a bit to cover today. I'm going to make sure I can, there we go. So in terms of the overview of today's training, we're going to talk about Medicare Part D, the counseling process. We're going to go over just kind of at a very broad level what are Medicare, Medicaid, QMB, also called QIMB, and the low-income subsidy. We're going to talk about how to use Medicare.gov to analyze clients' prescription drug plans, and then we will wrap up, answer any questions, and as Sylvia said, she'll come back and talk about next steps. So I'm going to do the first part of the training, which is the overview. I will then turn it over to Jess, who will handle walking folks through the online protocol for how to do the enrollments. So at a very broad level, and again, folks who have done this before are going to be generally familiar with this, but what is Medicare? Medicare is a federal public health insurance program. It consists of various parts. So Part A is hospital insurance. That's insurance for care that is delivered while someone is an inpatient at a hospital. Part B is medical insurance. That's for kind of primary care, outpatient care. Medicare Part D does have a premium for 2024. I believe the premium will be around $174.80 per month. And that can go up depending on someone's income. Medicare Part C is Medicare Advantage. That is essentially a privatized version of Medicare Part A and B. And a lot of Medicare Part C plans also offer a prescription drug benefit, which is what Medicare Part D is. I'll just quickly note that over the past few years, I do think we've been seeing more people enrolled in Medicare Part C plans. And, you know, some of them actually have a fine experience with the Medicare Part C and the analysis, you know, people can still look and check and see whether someone's drugs will be covered for the next year through the Medicare.gov plan finder, even if they are enrolled in a Medicare Part C plan. And then there's Medicare Part D, which has historically been the focus of this training, which is the section of Medicare that provides standalone prescription drug benefits. Unlike Medicare Part A and B, which are fee-for-service and administered directly by CMS, Medicare Part D is a series of private drug plans that each differ by cost and by which drugs they cover. How does Medicare Part D work? So as I said, Medicare Part D is a series of private plans. Those plans change every year from year to year in terms of which plans are available and what they cover. In 2024, that should say 2024, there are going to be 19 standalone plans in Washington, D.C., and 4 of those will be low-income subsidy or no premium plans for low-income beneficiaries. And almost all, or virtually all, of the clients that we assist through this project do qualify for some kind of low-income cost-sharing assistance. The annual open enrollment for Medicare Part D is between October 15th and December 7th of each year. But any plan change made during that period is going to be effective January 1st of the following year. So in this case, the plan changes that are made during the open enrollment are effective January 1st, 2024. Most people broadly enrolled in Medicare can only switch their plans during this open enrollment, except for a few exceptions. We will talk a little bit later in the training about how low-income beneficiaries do have a little bit more freedom to change their plans throughout the course of the year. But for the most part, people are limited to changing their Medicare Part D plan or their Part C plan to this open enrollment period. This does overlap a little bit with the ACA's open enrollment season. Those dates are on the PowerPoint, and we just like to include that in case people have any questions or get confused about the open enrollment period. The relevant open enrollment period for Medicare Part D is the October 15th to December 7th period. And as I mentioned, there are subsidies for low-income beneficiaries, and there are some additional privileges that those low-income beneficiaries are able to use in terms of switching their plans outside of the open enrollment season. So what is the low-income subsidy? Sometimes you'll also hear this referred to as extra help. This is financial assistance for paying the cost of Medicare Part D. People who are enrolled in the low-income subsidy, if they are also enrolled in a low-income subsidy plan, will pay no premium. They have no deductible, and they will also have essentially no donut hole. Now, I think the donut hole has already been kind of closed over the past few years, but it used to be a sort of coverage gap, depending on the total amount spent on medications, where people would pay a much higher percentage of their medication cost. But that is closed for people who are enrolled in the low-income subsidy. People who are enrolled in the low-income subsidy also pay lower copays for their drugs. There are a couple of different levels of assistance in the low-income subsidy, but for 2024, the copays will be either $1.55 for generic or $4.60 for generic drugs, or $4.50 or $11.20 for brand name drugs, depending on the level of assistance that people receive. A handful of medications will also have zero copays. Whether a medication has a zero copay tends to vary from plan to plan. And there are also $0 in copayments after $8,000 of cost, after the cost of someone's medications for the year reaches $8,000. That's widely referred to as the catastrophic coverage phase. In addition to the low-income subsidy, there are a couple of other programs that a lot of our beneficiaries are going to be enrolled in. So I just talked about Extra Help, the low-income subsidy. That is by itself a federal program administered through the Social Security Administration. And as I said, it pays entirely or it lowers the Part D premiums. So, there are a handful of plans that are not low-income subsidy, but the low-income subsidy will still lower the premium that someone has to pay, even if there is an out-of-pocket premium. And I went over the lower copays that people will pay for each medication at the pharmacy. In Washington, D.C., very, very few, if any, people have to apply directly for the low-income subsidy program. That is because in Washington, D.C., there is a separate benefit called the QMB, or Qualified Medicare Beneficiary, also called QMB benefit, which is a Medicare savings program. The QMB benefit has some benefits that go beyond the low-income subsidy, but people who are enrolled in QMB in Washington, D.C. are automatically enrolled into the low-income subsidy. So people who have QMB in DC do not have to separately apply for the low-income subsidy through Social Security. QMB is a Medicaid-funded program, but is administered locally like Medicaid programs are, and people in Washington, D.C. apply through the D.C. Economic Security Administration. As I said, people in QMB, they get all of the benefits of the low-income subsidy program, but they also get some additional benefits. The QMB program will pay a person's Medicare Part B premium. And it also eliminates co-pays and deductibles for Medicare covered services. So as I said, there's a $175 per month Medicare Part B premium. QMB will pay that. It will also pay for all the co-insurance and co-payments. So QMB saves people in DC who qualify a lot of money. And QMB, I think DC has maybe the highest income limit for QMB in the entire country. It's 300% of the federal poverty level. So it's a very generous program, and a lot of people benefit from this. A couple of things it does not do, however, it does not pay for any services that are not covered by Medicare. QMB is a Medicare cost sharing program. It is not a standalone health insurance program. So if something is not covered by Medicare, QMB does not let that person get that benefit. And it does not pay for medications that are excluded from the Medicare formulary. Again, that's because it's a wraparound cost sharing program for Medicare. It's not its own separate program with separate benefits. In addition to QMB, there are some people in Washington, D.C. with Medicare who also qualify for full Medicaid coverage. The income limit for full Medicaid for people with Medicare is substantially lower than the income limit for QMB. So I said the income limit for QMB is 300% of the federal poverty level. For full Medicaid, for most of the population, the income limit is 100% of the federal poverty level. But someone who has Medicare, who also gets enrolled in full Medicaid, and again, they would also apply through the DC Economic Security Administration, they will automatically get the low-income subsidy, and they will automatically get QMB. So they don't have to apply separately for LIS or QMB if people who have Medicare also get enrolled in full Medicaid. And just so you know, you might hear this term thrown around, people who enroll in full Medicaid, we tend to refer to as dual eligibles or duals. So in addition to LIS and QMB, Medicaid pays for Medicaid covered services after Medicare pays, or services that Medicare does not pay for at all. Medicare does pay for a lot of health services, and for anything that is covered by both Medicare and Medicaid, Medicare is the primary payer or payer of first resort. But there are a handful of things that Medicare does not pay for that Medicaid does. Two specific examples of that in DC are dental benefits. The DC Medicaid program has a very comprehensive dental benefit, whereas the Medicare standalone Medicare A and B does not have a dental plan. And also home health care services. DC Medicaid has a much more robust home health service program than Medicare does. And there are a handful of drugs that Medicaid may pay for if they are excluded from the Medicare formulary. So those are the three different tiers of financial assistance that people with Medicare in DC can get, depending on their income.